Well, thank you very much for joining us here. Esther, that was an incredible talk, and I think it did us all a great service with this session in showing why diversity matters beyond just being a moral good, why it matters for patients, and why it has been so difficult to achieve in healthcare. I think many of the issues that you began discussing are relevant to a wide range of different sectors and workforces. But I'm curious to hear from you in what ways do issues of discrimination play out specifically in the healthcare sector?
Well, I think you see it everywhere. I mean, women and racial and ethnic minorities, first of all, we have a problem starting from just the recruitment of students and recruitment of pre-med students, and then you see as we filter up to medical school and to residency, and then beyond. And then, patients come into the healthcare setting and are more and more expressing preferences and expecting to see people who look like them. So we're told that the opportunity is there, and we're putting more and more value on not just workforce diversification, but diversification of the highest leadership, because in corporate America, we're seeing that there's actually dollars and cents value there. So there's increasing expectation that we will be able to do that in healthcare so that it can trickle down to the value of healthcare that we provide. But if you don't feed the pipeline, you don't have that availability. So I think we're really struggling here.
And Patrice, what are your thoughts on that as someone who has ascended to the very top of that pipeline?
Pipeline issues are critical, but I think that we have to make sure that everyone takes ownership in pipeline issues, and that we have to start early on. This is truly an all-in proposition, and it really has to start in the 0 to 3 population in elementary school, in how we care for our children and make sure they have the appropriate educational opportunities, and make sure we nurture their socio-emotional development. And yes, I'm a psychiatrist, or a child psychiatrist, so I certainly think that's important. But I think we absolutely have to make sure that everyone takes ownership of the pipeline issue. I grew up in West Virginia, and I did not see in the flesh an African-American woman physician until after undergraduate. And it does matter. And so again, that's one of the opportunities I think I have for this year, is to be a living, breathing example that women can aspire to leadership, and particularly women and men of color. And I know that's an important issue in the pipeline as well.
Absolutely. And Damon, you've written an entire book about these kinds of experiences. What are your thoughts on this?
Well, yeah, my first time I actually saw an African-American male physician, I was in college, and that was actually a big part of my decision to go into medicine. If I think back to being a 14-year-old kid, I was like thinking about how pipeline things can work. I was in a lower income middle school, probably considered low performing. And the idea of becoming a doctor one day or being a writer, those things were totally inconceivable for me, for someone from my background. Parents and I attended college, anything of that sort. But I did have a teacher who was really, it was a magnet program that I was in my community, and they were trying to get minority students into this program, and speaking of how pipeline things work, and it was a STEM magnet program. And at first I thought, well, there's no way I'm gonna be able to go there. I'm gonna be one of the only black students here. It's not gonna work out, but this teacher really persisted. She called my mom after I declined. And because one of the things I think we think about in society is when we try and help people, sometimes we'll say, well, this person's rejecting the help, and not really understanding all the sort of context that goes into it. In any case, I ended up testing into this magnet program as a 9th grader, and that was the first time which I could sort of see my relationship to the world in a different way. When we talk about pipeline issues, the narratives in large society about what it means to be a black man are so often pervasively negative. And so and that affects, it comes down and affects individuals, and how do we begin to even reshape those sorts of issues? So for me, on a personal standpoint, those things are really very valuable.
And I think your story really highlights the role that a mentor and as we said, role models can play in helping to close some of these gaps.
Yeah, but the point, the initial question was about like, how do these issues of race impact medicine? One thing I think is really often overlooked is the ways in which the medical chart itself can be sort of its own form of perpetuating bias, because these things happen in every field. As an earlier speaker, Dr. Shaw said, in medicine you're kind of taught to the stereotype, like this is the problem with this person. You're often taught, you're giving a sort of snippet and you have to figure out what the issues are. And often in medicine, historically, there's just been this thing of age, race, and gender. So 30-year-old black woman, and then there are all these sort of assumptions that are supposed to sort of go into that. And often medicine sort of is teaching us in this sort of biased way, which is really, really problematic. And it's something that I think is often overlooked. And the ways in which that transmits, so one provider, you write a note in a chart, and how you frame things that impacts what that next provider sees the chart, and how you describe that person. It's like there's this tremendous power that's a story. This is what I try and tell medical students. Like when you're the doctor and you're writing a note in the chart, how much power you're conveying for that patient and their future interactions in the healthcare system. And so if you're interacting with people who may be very different from you, or you can't, or in some ways are uncomfortable dealing with, these things can sort of be transmitted into the chart and then perpetuated in further clinical encounters. These are the sort of things that are more subtle but are really important as we begin to sort of tackle these larger problems.
And so that speaks to some of the issues you raised in your talk about why diversity can make such among healthcare practitioners can make such a difference to the outcomes of patients, because you have that kind of congruence between the experiences of the people providing and receiving the healthcare.
Yeah, and I think the most reassuring thing when I look at the literature is that it doesn't have to be perfect concordance. I mean, obviously, when we study it, we want to study the value of what happens when you actually make perfect concordance. But it's not like I walk in the hospital and I'm like, I would really love a Korean American female doctor here, if I could at all. It doesn't really enter in our consciousness that that's something we would even think of. But the research shows that it is better even if you just have a generally diverse group, that there are a lot of different inputs when you're making the big decisions about how you're building your team or organizing a department or designing these systems, that there is heterogeneity of thought there that takes into account different backgrounds and cultures. I think even just that general diversity will filter down to the level of something that is really palpable for patients.
So we've discussed why this matters and some of the problems standing in our way, but I'd love to talk more about solutions. Patrice, you talked about taking ownership of these pipeline issues. What does that mean to you, and what do solutions look like to you?
Well, oftentimes when we look for solutions in silos.
Right.
Or we have expectations about whose responsibility it is to fix a problem. And that's why I say the solution to this is a systems problem. And we need the educational system to be involved in this, particularly elementary school education. We need to start before that. We need business involved. I mean, most businesses come to areas where there is good health care and there are great educational opportunities and they have an educated workforce. And so and a diverse workforce. Esther has definitely shown us the data is clear that better decisions are made when you have a diverse workforce. So I want to make sure, and I think we all should own this from the business community, from the educational community, from the urban transportation development community, everyone needs to own and make sure they have the commitment to solving this problem.
And what about the AMA in particular? What are your hopes for when you become president in June, is it?
In June, about a month away, yes. Thank you. Thank you.
Yeah, what are your hopes and plans for your presidency? How can you help? How can you use that?
Well, one of the great privileges of this responsibility is the platform. And I've said on many occasions that, first of all, I hope that just my face, again, can be tangible representation, that you can aspire, first of all, to be a physician, to be in healthcare, and further aspire to leadership. But I think it's the opportunity to continue to talk about it, continue to talk about the work of the AMA. We are about to embark on a journey of what I call our Health Equity 2.0 space. We've developed a center on health equity, and certainly looking at physician workforce and the diversity in the physician workforce is critical. But we also want to make sure that we address issues around the social determinants of health. I've had the opportunity for the last several years to chair the AMA's opioid task force, and you earlier asked about how we can see this manifest in healthcare. One of the many opportunities for learning was how we have approached those who have an opiate use disorder. Years ago, when it was mainly affecting Black and brown communities, our solution was to criminalize substance use disorder and incarceration. And now that the face of this epidemic is upper middle class white Americans, we are getting to treatment. Now, as a psychiatrist and someone who's been involved, and I know Damon is a psychiatrist too and appreciates stigma for many years, we appreciate now that we are moving from incarceration to treatment, but certainly we have to make sure that we appreciate the history of that. We're talking about implicit biases, and we know that there's some data that says that folks, physicians even, feel that African Americans, particularly African American males, feel less pain, and so perhaps they don't need appropriate pain care. And so these are all issues that are intertwined, and it's been an opportunity for me to amplify these issues, and I will continue to do so.
It's funny you say that because my back is hurting.
Okay.
Yikes.
I believe you.
Nice. Nice. I think another solution is in terms of the education piece. I think historically, medical educators have been adverse or kind of to talk about race. There's a lot of aversion to it. There's also a sense that, doctors like to think that they're experts almost on everything in some ways, and that, we've had all this education. Of course, we can't be racist. That's for people who are less educated. You'll hear people say these sorts of things. I have an MD and I have an MD PhD, but, the idea of, doing well in physics and in anatomy and these things, how that somehow would insulate you from all the other outside forces that can influence you is naive, but it's still pervasive, and it's something that we struggle with. Another challenge in teaching these subjects in a medical school setting is that there's this sort of idea that it's not hard science. We learn anatomy, we learn physiology, we learn biochemistry. We have to get, and the students often feel pressure to sort of to do well in that. And this is what we really need. This is what we need to know about medicine. And while it's nice to know about social determinants, they'll say, well, that's not, we're not getting tested on that. And unfortunately, all too often, you'll see that the expectation is that students of color are the ones who are supposed to teach the school about these issues, when instead of having experts and faculty from the other social science fields come in and talk to medical students, we're seeing students of color being expected to be the ones to educate people on these issues, whereas in contrast to the hard sciences, if you will, those are taught by the experts. And so there's always also this, students sort of get the sense of what's important to learn and what's not. But then when you get out in the real world, things are very different out in the real world of medicine. Like all the sort of, you have to be a competent medical provider, of course, but all those things only matter to the extent that you can relate it to the person that you're seeing and connected in help their healthcare.
I want to get back on this topic shortly, but before I do, Esther, can you tell us a bit about Time's Up Healthcare and what that means and what the goals are?
Yeah, with Time's Up Healthcare it's a large group of women. There's over 50 healthcare providers who are women, and also an advisory council. And we are an initiative of the Time's Up Global Foundation. And that was founded in response to the Me Too movement, where we really had a chance to see how women across industries are experiencing all the same thing. I mean, a ton of harassment, and that harassment is wrapped up in many different types of inequity in power and in compensation. And so the women in Hollywood wanted to have a robust response to it, and not just for themselves, not just for women of privilege, but really for everyone, those with the least agency and power to be able to stand up and actually meaningfully fight against harassment and discrimination in the workforce. And so we had an opportunity to meet with those leaders, a few of us in healthcare who had concerns about these issues, and it was clear that this was a good fit for healthcare as well. We are the largest industry in the United States. We've recently had data that shows how egregious these problems are in healthcare. And for us too, we just have this particular obligation to really address this with urgency and with rigor, because it is clearly playing out in the lives of our patients. If we don't address these workforce issues, the House of Medicine is not really prepared to bring in the diverse body of patients and take good care of them. We simply can't do it in the current climate. And so we launched just in March 1st. We're the fifth initiative of Time's Up Global. and we're just getting started. But what we want to do is kind of bring the framework of healthcare quality to these issues of harassment and discrimination. You know, I feel like when you talk to people who finally understand that they need to do serious work in their organizations to make the healthcare environment better, they're like, it's so complicated. How could we possibly fix this? And I'm thinking, we have this whole framework for healthcare, you know, improving healthcare quality. You know, we put the systems in place, we make sure we have rigorous processes, and then we have very carefully laid out precise measurements of outcomes. That's what we need to do to improve our healthcare culture, and we do none of it. We don't even measure adequately. So, you know, how do you improve something if you can't set a target? How do you set a target without having any metrics at all? But that's kind of how we treat problems of sexism and racism and harassment. We kind of just decide that we're going to not look under the hood and just hope that things are doing well enough on their own there.
Yeah.
So in a moment, I'll be going to questions. So please start thinking about what you want to ask and type them in. Don't forget to include your name, title, and organization. But just before we do that, I have one last question, which is that I think often the burden of dealing with these problems of gender and racial disparities falls disproportionately on people of color and on women and women of color. And what can allies do to help? Like, what can people who aren't us chip in?
Yeah, I mean, for those of you who think that, I mean, there's some really outrageous examples that are still occurring even within medicine. I've had a chance over the last few years to meet many students and many doctors all across the country. I'll give you a couple examples. On the front of gender, a student told me that there are certain training programs where they're still bringing primarily male applicants to gentlemen's clubs as part of their interview. And I'm thinking, how could that possibly be happening? And so you would think that, you know, as a man, that, you know, if something like, you know, something that's going on, you have to sort of say something, right? Say, this is outrageous, you can't do this. But there's obviously a lot of layers of things that are occurring. There are people that are overlooking this or not saying anything, allowing this to happen. On the race front, you know, I've had students tell me examples of a doctor referred to a young black girl as a pickaninny, which is a very derogatory Jim Crow era term. And then she was the only minority student there in the whole team, and she felt like, what do I do here? Everyone's looking to her to react. She's the lowest person on the totem pole. So many other people could have spoken out along the way. And so it doesn't. You don't have to be that member of that group or identified minority to sort of acknowledge things are wrong and speak out. So I think these things there's many egregious things that are occurring, and I would say that I would encourage people to feel more empowered to sort of, you know, you're in the room and you say, no, it's not acceptable, you can't do this, you can't say this.
Okay.
So.
Let's go to questions. So the top one by Anonymous is, we're taught as doctors to make most likely diagnoses. How do we balance our understanding of the prevalence of diseases and also reject profiling of patients?
I think a good start, and this is a good start for any organization, but it's to do your own or go through formal implicit bias training. Mm-hmm. Because these are hard conversations and they require some support and some help. And if we all were aware of our own biases, right, a lot of these things wouldn't happen. And we all have them, even folks of color and folks of privilege. So I think it's important that organizations commit to, first of all, an organizational assessment, and then making sure that everyone on the team has implicit bias training. And I would say, you asked earlier, what can allies do? And I think it is speak up. Because the medical student really isn't in a position to speak up and shouldn't be the only one that is asked to speak up. So we need allies, again, to educate themselves and to speak up when others can't.
Yeah, I feel like that value of implicit bias training also touches on what Damon hinted at. It gives you a shared vocabulary to talk about these problems that are quite tricky and for people who haven't experienced them before. So we have another question in. What do you think about Beth Israel's Open Notes initiative of allowing patients to see all doctor notes to address stigma by changing how doctors write those notes?
Yeah, that kind of was echoing on something I mentioned earlier. There's no perfect, approach to this. I'm in psychiatry, where it's just historically been one of the fields where you're most likely to have these sort of notes that are private, and not because you worry about how the person might receive the information. I'm in a setting where the notes are open, And I honestly have thought it's actually maybe more hasn't reduced my quality of care in any way. It's actually, initially, as anything, we always resist change. You know, that's just a natural impulse all of us have. But I think over time, it's actually been very helpful, honestly. And I have not had any downside to it. It's made me rethink some of the things that I put in people's charts. And like, why? Because sometimes what I'll say is like, I'll tell a student, like, why do you include that piece of information? Why is it important? And if you can't come with a clinically relevant reason for putting it in there, then probably it shouldn't be in there, right? But people do it all the time. And so that's sort of the ways in which I think this thing can be really helpful.
Okay. Esther, do you feel a growing sense of momentum around these issues that you've raised in your talk? Do you think that things are changing?
Well, I am encouraged that more people want to talk about it. I would say that. I mean, when we do prognostication, I think almost anybody who's involved in the inclusion and equity work says, it might be a little better for my children, or maybe for my children's children. I don't think that those of us in our careers right now feel that it will be profoundly different within the course of our career. But the encouraging thing is people want to talk about it. There's more forums than ever, I feel like. I mean, it went from 5 years ago, literally, I would say, I'd like to come and give a talk about gender bias, and people would say, can you talk about anything else? And now I'm booked through, almost the end of 2020 with requests to talk about gender bias and racism and sexual harassment in healthcare. That, to me, is a very promising shift.
Yeah, I would agree. When I was in medical school, we had 1 hour discussion on race, had 0 on anything about gender. And I would say that as students, we weren't really that interested in it ourselves. I think the types of people that are going to medical school now, there's been somewhat of a change. Medical students now are more invested and interested in these types of issues, and I think that's going to signal a future change. Because our generation was very much more in the, I'm guilty of it myself. We would say things, very derogatory things like about social determinants of health. We would say, well, we went to med school to be doctors, not social workers. Those are social work problems. It's just sort of pervasive term that would be used a lot. But now students are very different now, and so I think that's a real signal for change and hope.
So we have another question. What are your thoughts on the role of affirmative action within the medical community?
Well, I'll just mention the AMA's recent statement, and hopefully most of you saw our statement from our current president, Barbara McEnany, regarding the Texas Tech decision. I know that we certainly were vocal in that statement regarding our concerns regarding that decision, and certainly we were amicus. We filed an amicus brief in the Fisher case earlier on. So I would say, first of all, we want to make sure that we have a definition of affirmative action. I think most folks are looking at, and I'm specifically talking about medical school admissions now, holistic admissions. And I think many admissions committees will say that they get a more diverse medical school class when they participate in exercises where they blind everyone to names even, and where you went to school, and anything that might alert the admission committee members to someone's race and ethnicity. And there is increased diversity. On the other hand, we need to know that information. That is helpful. So again, no one right way, but I think that the AMA has gone on record about the importance of looking at admissions holistically and appreciating and valuing diversity in that process.
Okay. Do either of you have thoughts on the affirmative action question?
I have my eye on the next question.
Sure, all right.
That seems destined for me.
All right.
I'll step back.
From Eric from the Harvard School of Public Health, what should the social response be to people who've committed racist or sexist actions, and can they be redeemed?
I just want to make clear that we all commit racist and sexist actions. Can we agree on that? Yeah. And the problem that I want to address here is that when you see overt cases of sexism or racism in the media, that is so definitively bad. It's usually a dumpster fire of a case. And the problem is, in healthcare, we don't actually respond well to allegations of sexism or racism unless it is that egregious. And everything that we see is this teeny tiny tip of a ginormous iceberg. We don't treat this like we treat health problems where we try to do screening before something is symptomatic. And so the analogy I use is if sexism and racism and harassment, if these things were cancers, we would just kind of wait until they were full-blown and metastatic before we address them. And then we expect to be able to cure them. And that is not how you can eradicate a system. You can't wait that long. You have to start when they're just minimally symptomatic or even asymptomatic and really detect what's going on under the surface. So of course, there is redemption. However, we have to start talking about little cases, what we call microaggressions that actually should not be called micro because they have profound impact on people's ability to operate well in the workplace. But we need to start on these little actions, and we should take this whole body of sexist and racist actions that play out every single day in healthcare, and we do need to respond to them. We need to talk about them the way that we talk about other improvements in healthcare quality. I mean, when you have an M&M, morbidity and mortality, a sort of a quality improvement case, you don't get fired, you don't get suspended. What happens is you all come together as a community and you talk about how to make sure that doesn't happen again. And so I really want to bring that M&M, that QI model to incidents where there is clear sexism and racism.
Well, hopefully this conversation will spur many more like it, but thank you so much for joining us today.
Thank you.
Thank you.